Morning. Welcome everyone to Friday morning conference. It's my great pleasure and great disappointment to introduce Dr. Paul Hansen. I was going to do this little speech about how excited it was, and we had this wonderful surgeon here in Missoula, and we could draw this. It turns out he's in Portland, but he is the head of the Providence System hepatobiliary surgical program, and he's available to anybody by telephone if you want to talk to him. Dr. Hansen got his MD and at University of Washington, and then went to University of San Francisco for general surgery and some subspecialty. And then, remarkably, went to the Royal College in London to study hepatobiliary and pancreatic surgery. And he said, it's a wonderful quote I want to share with you. I spent 10 years in surgical training developing the technical skills I would use for a career in minimally invasive and liver and pancreas surgery. My real education, however, has come in my practice, when I have learned to apply those skills individually to patients. Each patient presents a unique set of challenges, both medical and social. Meeting my patients and taking the time to understand their needs, desires, and expectations will ultimately help assure that they get the best outcome possible. And best of all, he's a birth Montanan.
Thank you for that kind introduction. I was born in Montana. I use every opportunity, as Christy knows, to get back to Missoula or anywhere in Montana for that matter. I born in Great Falls, raised in the city between Seattle and a lot of time on Flatbed Lake, and lived now in Portland, Oregon for the last 20 years. Although the goal of getting up to Montana to spend a few years in practice would be wonderful. I'm going to talk. I was asked to talk a little bit this morning about pancreatic cancer and some of the breakthroughs that seem to be slowly working their way into the system. We were just chatting a little bit about kind of how bad pancreatic cancer is, and I guess I would start by saying that I think of pancreatic cancer today much like we thought about testicular cancer back in the 1970s. If you walked in the door with a diagnosis of testicular cancer in the 1970s, you had about a 5% chance of being alive in 5 years. It wasn't one change, it was probably 40 or 50 changes that ultimately over the next 30 years got us to the point where today, if you're diagnosed with testicular cancer, your chance of being alive in 5 years is about 95%. And so each of these cancers has very unique features about them that it's not like we're going to come up with one drug that's going to cure all cancers. Every one is going to have to be addressed very independently. And so we're really getting into this personalized health care and understanding the genomics, the proteomics, and the microbiomics and how they all affect the progression of cancer. Pancreas is just a particularly difficult one. So I'm going to talk a little bit about the magnitude of the problem. I'm going to talk about the initiation of the evaluation. We'll talk a little bit about the evolving role of neoadjuvant care in pancreatic cancer, and then also just mention briefly at the end surgical rehabilitation, which is kind of a new concept and that is playing a very important role for us in the outcomes of our patients after the surgery. And yes, that is sweetbreads, and I haven't been able to eat those for about 20 years now. So pancreas cancer, it remains one of our biggest medical challenges. As I said, in 2013, some 50,000 people in the United States were diagnosed with pancreatic cancer. About 38,000 died. And the incidence is unfortunately slowly increasing with time. The Oregon State Cancer Registry shows us about 550 pancreatic cancers are diagnosed each year. Montana has roughly quarter to a third of the population of Oregon, and so you can use these numbers. You can imagine there's probably about 150 cases of pancreatic cancer in Montana a year, so it's not a trivial number. The death rates from cancers is changing. We've made a lot of progress over the last several years, and so you can see that gastric cancer really kind of started to go away in the 1970s, but more recently what we see is that colon cancer, this is largely due to screening, prostate cancers, similarly screening and treatment, and lung cancer. And this is the decrease in smoking. But as you look at the curves on all of these, the one, the pancreas being in red, the trajectory is not good for pancreas, and it looks like it will at some point in the near future become the second or even the leading cause of cancer death in men. And this is similar in women. So stomach and uterus dropped away some time ago, colon's dropping away, breast is dropping away, lung is dropping away, but pancreas is remaining out there as an unchanged cause of mortality in cancer. And the reasons for the poor survival are multifactorial. So part of it is this insidious presentation. These patients, as you know, they'll often tell me, well, for the last year I've been having some low-grade indigestion or nausea or some weight loss. I wasn't really dieting, but I just didn't seem to need to, and I started taking some weight off. The cancers themselves have an aggressive behavior. They have an early development of involvement of the blood vessels and vasculature. They spread to regional nodes pretty early on, and they have early systemic spread. It's not uncommon to have a 1.5 centimeter pancreatic head tumor with a liver chock full of big metastasis and metastasis in the lungs. They have some sort of a de novo chemoresistance, which is poorly understood at this point. And they behave quite differently than a lot of cancers. I don't know if any of you have ever had a chance to see a pancreatic cancer. This is a cut margin of a pancreatic cancer. This is a duct, and the tumor is in here, but it's this scirrhous growth pattern that kind of reaches out with little fingerlings to all of to other parts of the pancreas. And if you get a histologic slide, this is commonly what you see. It's not one big lump of tissue, but you'll see these little dots of cells that are farther out into the tissue. And so this is a slide that came out of a European analysis, pathologic analysis of cancers. And what they looked at is, if you've ever seen a colon cancer, liver metastasis, they're red, they're round, they're firm, they basically grow as a lump that pushes everything else out of its way. And if you start in the center of this tumor and you do an H&E stain and look at the cancer cells in the center of the tumor, closer to the periphery and at the periphery, it really doesn't change very much. So this is a digital image of this, where we've taken and marked, they've taken and marked each of the cancer cells with a pixel. And so you can see the distribution of actual cancer cells in the center, a little bit further towards the periphery. And the periphery really doesn't change very much. It's very different in pancreatic cancer. So this is the center of the pancreatic cancer cell, a little closer to the periphery, and this is on the margin. And you can see that the density of cells drops off tremendously, and on average it's about 31, the density of the cancer cells out here in the periphery is about 31% of the center of the tumor. And so you can imagine that wreaks havoc when you're trying to understand the margins. You'll see here in a moment that margins are very important for us. As we cut across the pancreas, we take a look at a histologic look at the edge of what we've cut to see if there's cancer there. Do we have it all, or have we cut across cancer? And it becomes very difficult to understand that difference. So I'll jump from that for a moment to just presentation. So as I said, these patients present with insidious onset. They walk in the door once they develop jaundice, typically, or quite severe abdominal pain. Weight loss, it's common for patients to tell me they've lost 30 to 50 pounds in the last year. There's no acceptable screening tools, unfortunately. There's no blood test, there's no imaging study, there are no markers that we have that can tell us that you have a pancreatic cancer developing inside you. So the initial evaluation once they walk in the door is the history and physical and labs. The only tumor marker that we have that works with pancreatic cancer is CA19-9, and it's not a very good one. The problem is that it's a non-specific antigen, and it's elevated with any sort of ductal inflammation or obstruction. That means both biliary ductal and pancreatic ductal. So if the patients walk in the door jaundice with bilirubin of 15, their CA19-9 is meaningless, because whether it's stones or cancer, their CA19-9 is going to be elevated. So once they're stented and the jaundice has cleared for a couple of weeks, and then you measure it. If you have a CA19-9 that remains above a level of 100, that's associated with cancer, and if you have a CA19-9 above 1,000, that's associated with a very poor outcome. You still get survivors at that level, but they generally don't do as well. And so if you have a clinical suspicion of a pancreatic cancer, step number one is always a pancreatic protocol CT scan. This is by the NCCN guidelines. It's what most institutions that I'm aware of do, and we certainly do it. What we mean by a pancreatic protocol CT scan is that it's a timed arterial infusion, and so what you do is you actually start with a non-contrast scan, so just to see what things look like at baseline, and then they give the injection, and they do a quick arterial scan, a quick venous phase scan, and then the fourth phase that some people do is an equilibrium scan. And these are they're very good, very high quality scans, 1 to 3 millimeter cuts, 3D reconstructions. And the images that they produce are really quite outstanding, but the ability to determine exactly where pancreatic cancer is, you can see, is really quite marginal. If you look at this is a little bit of more normal fluffy tissue of the unsnip process, and there's actually a tumor that's sitting right in this area here. They tend to be a little bit hypovascular, so it's right here on this patient, so they're a little bit darker than you would normally expect them to be, but as good as the scanning is, it's still quite a challenging diagnosis to make on CT. And I'll tell you that these pancreatic protocol CTs, one of our goals, Oregon is not that dissimilar to Montana in the sense that we have areas where there's larger population, but about half of our population is scattered throughout the much broader community. It's the 9th largest state in the country. And one of our goals is to get as much of the care done at the sites where the patients are coming from as possible. So they might need to have their surgical care at a center that's a high volume center, but you should really be able to do the rest of this at other sites. And so any high quality CT scan these days can generate this quality of an image. For staging chest and pelvic CT scans is what we use to complete the staging once we're getting the patients ready for surgery. But if you identify a solid mass in the pancreas, about 85% of the time it's going to be a pancreatic cancer. There are a handful of other cancers, cholangiomas, amphillaries, PNETs. They can have a slightly different appearance. But you can tell that if 95% of these solid masses are adenocarcinomas, that's typically not a good outcome. Lymphoma is only about 1%. Chronic pancreatitis makes up a handful of these solid masses. And then there's a newer entity that we're really beginning to understand a little bit better, and this is autoimmune pancreatitis. And these are these patients who have these sausage-like pancreases on CT scanning, and so it's this big, full look to it. It's very kind of homogeneous in appearance, and it just has a slightly different look than the typical solid mass in the pancreas. And so if there's any concern about the diagnosis here, or if you biopsy this and you're just getting inflammatory cells, which is often the case even with pancreatic cancer, you may want to look at an IgG4. We do this pretty routinely in our patients these days. And if IgG4 is elevated, you might want to try a 2 to 4 week trial of steroids, and that can make these inflammatory masses completely disappear. I've had a couple of cases that I've been pleasantly surprised by recently, that we were setting them up for surgical resection, and somebody got the bright idea to give them steroids. The lesion disappeared and patients were fine. So PET CTs, there's often a question about whether or not we should be doing PET CTs in patients with presumptive diagnosis of pancreatic cancer. The role of this is evolving. It's a very good study. It's about the same as far as its sensitivity currently with CT alone in defining whether or not you have pancreatic cancer, but probably more importantly, what we use these for is identifying metastatic disease. And if you mix a pancreatic protocol CT with a PET CT, we're about 85 to 90% accurate in being able to diagnose it as a likely pancreatic cancer and showing whether or not they've got metastatic disease. We tend to use it relatively selectively. So if the patient has a questionable CT scan that just isn't really giving us, the CT is not giving us the answer, if they have a particularly high CA19-9, that means they're likely to have metastatic lesions. And so some of these won't show up very well on a chest CT, or if it's a particularly high surgical risk patient, and I'm really looking for a reason not to operate on that patient, we'll often get a PET scan. After the CT scan, usually the next step for us is an endoscopic ultrasound. I understand there's a new US doc here, which is a great resource for you to have. So we tend to use it rather routinely. NCCN suggests it be a little bit more selective. It's very operator dependent, meaning it depends on how often they're doing these. It takes a while to get really good at them. What they're looking at is again, it's fairly ill-defined in some patients. This is a pretty well-defined tumor here, leaning up against the portal vein, but there's probably a nice backplane between this tumor and the portal vein. They can get biopsies, which is really the critical component for us these days. So we use it to help identify vascular involvement, to look at nodal status. They can biopsy lymph nodes if they look concerning. And then we routinely biopsy the tumors. And for us, we feel that the confirmation of diagnosis, number one, really eases the decision-making process. You're talking about doing very morbid operations on patients, and you really, it can be a tough decision for the patient and the family. And so if you know it's a pancreatic cancer, it's a little bit easier to make that decision. The other thing we use it for, actually more commonly, as you'll see here in a minute, is we are very heavily leaning on neoadjuvant treatment, which means giving chemotherapy and potentially radiation therapy prior to their surgical intervention. And you don't want to give them a long, heavy-duty course of chemo and radiation if you're wrong. You got it's actually a PNET or some other diagnosis. If the first US biopsy is not confirmative of the diagnosis, but we really think it is a cancer, we'll actually just go back and repeat it with a second US biopsy. And if that's negative, we'll consider a CT-guided biopsy. Before you give neoadjuvant treatment, you really have to have that diagnosis. And then finally, ERCP. This plays quite a bit, a kind of a lesser role today in diagnosis than it used to. They used to talk about double duck signs, and this was an early way that we would diagnose pancreatic cancers. What we really use it for today is this, for stenting. These patients typically frequently present with biliary obstruction. The bile duct runs right through the cancer and it's being compressed. These patients, if they're going to get neoadjuvant treatment, they'll need some 3 to 6 months worth of treatment prior to surgery, and obviously you can't leave a patient jaundiced for that length of time. So if we have a patient that's either clearly unresectable or a potential candidate for neoadjuvant treatment, we do push our GI docs to go ahead and put in either a short metallic stent, as long as they keep it below the biliary bifurcation, that's fine. Some people think the expandable metallic stents are too expensive, and you can use these very inexpensive plastic stents, which work very well. But if you only put one in, it'll only last somewhere between 1 and 3 months before they get obstructed. You don't want these patients on chemo showing up with cholangitis. And so if you're going to use plastic stents, we like to see at least 2 or 3 of those stents placed. So with the diagnosis, the details of the diagnosis worked out a little bit. At that point, we moved to what I think is absolutely the most critical step, and that's the presentation of the multidisciplinary tumor board. And we live and die by this board, and I'm amazed at how often I've been doing it for this for almost 20 years now, and I think I understand this disease process relatively well. And I'll tell you, probably a quarter to a half of the time, my decision is significantly altered by what I learned at the multidisciplinary tumor presentation still. So we have a group of HPV surgeons, med-onc, rad-onc, we've got diagnostic and interventional radiology, we've got actively involved GI docs, and then we're very aggressive about trying to get these patients into clinical research. We're very frustrated at the rate that we're able to improve the care that we're giving to these patients, and yet only 4% of patients with pancreatic cancer are currently enrolled in clinical trials. And it's not a large number of patients to begin with. So unless we get these patients on clinical trials, we're never going to be able to answer the questions we need to get answered. So we present all of our pancreatic cancer patients there. We're very heavily driven by NCCN guidelines. We have a very clear-cut patient care pathway for pancreatic cancer. And as I said, we work very hard to get these people on trials. So the outcomes are really dependent on the stage of presentation, and this is one of our big problems, of course, is that more than half of the patients show up with late-stage disease. So these patients are already metastatic when they walk in the door, and really all we can do is palliative treatment. About a quarter of the patients have nodal disease, and only a very small percentage, about 10, have local-only disease. And you can see if they've got local-only disease, we can cure somewhere between 20 and maybe up to 35%, some of the newer data. With nodal disease, it's probably between 10 and 15% cure rates, and then once they have metastatic disease, cures are essentially not happening. So I won't beat on the TNM staging, but it is important to understand there's some interesting features of this that can help us guide us through our treatment process. So the first is the T staging of the tumors. And that really tells us that the small T1s are small tumors, less than 2 centimeters. I see out of the 100 pancreatic cancers a year we see, I'll probably see 3 or 4 that have T1 tumors. The vast majority are T2 or T2, T3, or T4. So 2s are larger than 2 centimeters, but they're not invading into anything else. T3s are, doesn't matter what size they are, but as soon as they invade into the duodenum or the peripancreatic tissue, they become T3s. And then N1, nodal disease, is still considered early stage disease as long as it's regional nodes only. And so those are all considered, historically, that's the group that we operate on. The patients that we tend not to have not operated on, the M1, anybody who's got metastatic disease is not a candidate for surgical resection. Very occasional, I'll have somebody who's who doesn't have extensive metastatic disease, but they're bleeding to death from a T3 or T4 lesion in the duodenum, and we might do a palliative Whipple in those patients. And the outcomes in Whipples today, last time I was here about 3 years ago or 4 years ago, I talked about technical aspects of the Whipple operations and the distal pancreatectomies. Patients do much better today than historically. So this old concept that everybody dies of a Whipple, or if you have a Whipple, you have a horrible life afterwards, is just not true. And so I'd love to talk to you more about that after the lecture maybe, but people do much better today with surgery. But if they've got metastatic disease, generally try not to do it. These T4 lesions, there's a lot of change in our understanding at this point. So these are the lesions that involve the vasculature, either the superior mesenteric or portal vein, or the superior mesenteric artery, or the celiac artery and its branches. And it's not uncommon that these cancers involve these structures, but we're starting to understand that the degree of vascular involvement can be affected by our preoperative treatment. And so we're operating on a lot more of those patients than we used to. Surgery is still the only way to cure these patients. And so, unfortunately, only 15 to 20% of patients who walk in the door have local only or nodal only disease. And so these are the patients we operate on. But you can see in general, the group that we operate on versus the group that we don't operate on, it's that there is a bit of a difference. We can get about a 20% long-term survival with essentially a 0% long-term survival in patients who do not get chemo or not get surgery today. So this is consistent with the NCCN guidelines. If it's resectable, and you'll see borderline resectable as well, they recommend that you at some point move on to a surgical exploration and resect if at all possible. The outcomes are dependent on a couple of factors. The size of the tumor, obviously, is one because of the involvements in the other structures, but also it is dependent on nodal status. And so if we have a small tumor with no nodes involved, we might be able to cure a third of those patients. If the nodes are involved, that cure rate drops in about half. We still get some long-term survivors in these groups, in these patients who have nodal disease, but not as often. And the next thing that involves long-term survival is our margin positivity. Again, this is where we're going to cut across the tumor. The pathologist looks at the cut surface of what I've taken, and if there's cancer there, then that's a positive margin. There are two types of positive margin. An R0 margin means there's no cancer. An R1 margin means there's microscopically positive cancer. And an R2 margin is a grossly positive. You can just look at it and say, yeah, there's clearly cancer there. And so if you look at in the red here in all of these studies, in the red is patients who have an R1 or an R2 margin, and their survival is always shorter than patients who have an R0 margin here in the green, and it's across the board. Probably more interesting in this particular slide is this right here. So this is a huge number of patients from Johns Hopkins. And when they look at their pathology specimens, they're about a 50-50 mix of R0 versus R1 and R2. And if you look at, and that's true, here's Mass General's numbers, but if you look at, for example, Leeds, where they have a very aggressive group of pathologists, they're telling us that 85% of their margins are positive. And technically, these surgeons, the pancreatic surgery today is really done in a very similar fashion. So I don't believe that the lead surgeons are doing a different operation than the Hopkins surgeons. Here at Naples and at Luke's St. Luke's Presbyterian, the margin negativity rate is very low, about 20%. The margin positivity rate is very low at 20%, and the margin negativity rate is high. I think that this is probably pathologists that are not looking as hard as they might for positive margins. This doesn't project very well, but there's a woman by the name of Rebecca, who's a pathologist from the Netherlands. She's done this amazing job of looking at how we pathologically analyze these pancreas specimens. And what she's been able to show is that if you do these particular axial slices, you get a much better understanding of whether or not the margins are positive. And as I said, with that spirus spread of these pancreatic cancers, you may only be looking for 1 or 2 cells on the cut surface of the pancreas that will show you that you truly have a margin positive lesion. And that becomes important here because in the old days, historically, we broke pancreatic cancers down into resectable and unresectable. Our life was pretty simple. But there was a big difference in where the surgeon trained. Some surgeons were very aggressive and some surgeons were not very aggressive. And so a resectable lesion was 2 centimeters or less, and it wasn't touching any of the vasculature, and that was resectable. But if it touched the vasculature, there were many surgeons who said, well, that's you really shouldn't be resecting that. There are surgeons that come out of institutions that were being more aggressive, and they actually said, well, you actually can resect those. All you have to do is peel it off the vein, or maybe even take out a segment of the vein. And so if they had a tumor which was abutting up against the superior mesenteric vein, they might take a piece of the internal jugular and they would resect the superior mesenteric vein and then graft in the internal jugular vein, and they were able to demonstrate that they were getting long-term survivorship that wasn't all that different than if in patients where the tumor wasn't touching the vein. So it really started pushing people to think about how aggressive we should be. Unresectable, metastatic has always been characterized as unresectable, but we've pushed this even to the point with vascular involvement that even locally advanced tumors are now being reconsidered for resection. Borderline resectables, so that led to the creation of this borderline resectable group that's in between resectable and unresectable, and it's really based on the degree of vascular involvement. There are 4 different sets of guidelines, but they're all pretty close to each other, and they have to do with the degree of involvement in the portal vein and superior mesenteric vein, whether it's abutting it, whether it's hinging upon it, whether it's encircling it from both sides, or whether it's even obstructing it. The bottom line for resectability is that you have to have something that you can reconstruct. So if I can cut above it and below it, on this one I can cut above and below, and I can sew those two ends together or put in a jump graft and have adequate blood flow. Whereas here, where the tumor comes down to a point where I've got 2 smaller vessels leading to a large one, there's just no good way to reconstruct that. So that's an unreconstructible vessel. And so this one would fall into this locally advanced group right here. And then the other issue is the degree of abutment of the major arterial structures. And this was a little bit arbitrary, but they had to start someplace. And so it was called borderline resectable if the degree of abutment of the tumor, which is here in the head of the pancreas, that's the superior mesenteric artery, and if that degree of abutment was less than 180 degrees, it was considered borderline resectable, and if it was more than 180 degrees, it was considered unresectable. It's kind of a crazy arbitrary definition, but as I said, they had to start someplace. So if you have more than 180 degrees, you were considered locally advanced, and initially you were considered locally unresectable, but that's starting to change at this point. The reason it's starting to change is because we're starting to look a little bit more at this potential for neoadjuvant treatment. And so the arguments for neoadjuvant treatment are multiple. The first is that this is a systemic disease. We all know that if you do a successful resection on a patient with pancreatic cancer, about 80% of those patients are going to die with metastatic disease. So whatever you do locally on the head of the pancreas or the body tail of the pancreas isn't going to matter in somebody who's going to end up with liver and lung mets. So we have to figure out a way to treat them systemically. Unfortunately, even about a third of those patients that show up with metastatic disease do so shortly after their surgery. So you do the surgery, and then on their 4-month CT scan, they've got lung mets. Well, you know that surgery was a complete waste. And so is there any way that we can identify these patients prior to taking them to the operating room? It's a very morbid surgery, so let's say you take this patient to they look like they've got a good resectable lesion. You go in and resect them with the idea that you're going to give them systemic chemotherapy later. Only about 2/3 of the patients actually get their systemic chemotherapy. About a third of the patients don't get it because the surgery is relatively morbid, or the surgery is advanced in the interim between the surgery and the time that they would get their chemo. So So being able to give systemic chemotherapy up front is probably more valuable. And then complete resection is critical, as I've said. And so can we use the neoadjuvant to increase our R0 rate? And so this is, again, a pretty classic cancer where the lesion itself met resectability criteria, but this is that desmoplastic reaction. You see this inflammatory stranding that wraps around the superior mesenteric artery. This is a patient that I would argue, if you really look carefully enough at this inflammatory stranding, you're probably going to see some cancer cells that are reaching out there. But most surgeons will end up transecting this piece of tissue right here, and then you'll leave all that inflammatory stranding behind. That's just you can't go get all that tissue around the superior mesenteric artery. And so if there are microscopic foci of cancer out there, can they be treated by chemotherapy ahead of time? Well, that's all good, but you have to have chemotherapeutics that work. And historically in pancreatic cancer, we haven't had any good drugs. That's beginning to change. Can the patients tolerate the treatment, and does the chemotherapy itself prevent the patient from then going on to be able to get surgery? If you make them really sick with your chemotherapy and then you can't do the only curative treatment, which is the surgery, then that's probably not a good thing. And so the first question, do we have chemotherapeutics that work? And there historically, for the last 20 to 30 years, there are a number of trials that looked at 5-FU with the SPAC trials, and it suggested that, we don't have to go through the details of this slide, but the bottom line is that the chemotherapy did seem to benefit patients either with metastatic disease or in the adjuvant setting. Similarly, there were several trials that came out looking at gemcitabine, and it did seem to benefit patients overall. Primarily, it was looked at in the palliative setting if they've got metastatic disease, but it was also looked at in the adjuvant setting and seemed to have some benefit. But the response rate, meaning that tumors actually shrink down from the cancer, 5% of tumors actually shrank, which means at best you're probably going to get the cancer to hold still for a little while, but more likely you might slow it down a little bit, but it's still going to progress pretty quickly. And so we were all very pleasantly surprised at this initial publication in New England Journal in 2011 at the relatively new combination of FOLFIRINOX. So it's 5-FU, irinotecan, and oxaliplatin are kind of the backbone of this regimen. And we gave it to patients and this is in the metastatic setting, so these are patients who are stage 4. You're not looking at doing surgery on them. But what they found was there was a clear benefit to survival, even over to the gemcitabine, which had been shown to be beneficial over nothing at all. And on top of that, what they found was there was an overall response rate of 31%. A third of the tumors were actually shrinking with this treatment. And that's something we had just never seen before, compared to in this trial, about 10% of the gemcitabine tumors shrank with chemotherapy. This was followed up 2 years later by another New England Journal. You can tell that when anything looks good in pancreatic cancer, it makes it to the New England Journal fairly quickly. And in 2013, they looked at this nab-paclitaxel or Abraxane mixed with given with gemcitabine. And again, very large trials. These were metastatic patients, but the patients who got the gem Abraxane did far better than the patients who, or not far, but they did better than the patients that got gem only. And again, the response rate was 23% over the 7% with the gem alone, giving us these two-side survival curves, which showed some degree of separation. So suddenly we had some chemotherapeutic treatments that actually looked like they may be benefiting. So again, I'm back in the 1970s looking at testicular cancer. This was the first type of little tiny bumps that we saw in the management of testicular cancer. So that's great. We've got things that work, but do they make the patients too sick? Because both of these treatments have some significant toxicities, FOLFIRINOX in particular, where you can give patients fatigue and diarrhea. They'll often lose weight, although interestingly, if they've got pancreatic cancer, they often actually gain weight once you start treating the tumor. Neutropenia, febrile neutropenia, and neuropathies can be pretty bad. And so were we going to make these patients too sick with their chemo to get their curative treatment? And the answer is probably not. There were a number of smaller studies looking at neoadjuvant regimens. This particular one would use 90 patients looking at gemcitabine and cisplatin with XRT. 80 of the patients actually completed the pre-op chemotherapy. Of the 11 who didn't make it through their treatment, Even in those patients, 3 of them actually ended up getting resected. Of the 80 patients that did make it through their entire treatment, they only lost 4 patients that were not able to undergo their surgery. And so the answer is, yeah, probably during the chemotherapy, you're going to lose a few patients to either progression of disease or to the toxicities of the treatment. But it's probably a reasonable trade-off if we can if we can improve our margin negativity rate and prevent the earlier recurrence of cancers. And then there are some surgical issues, which does it make the surgery harder or unsafe, and does it actually improve our resection margins as we were hoping that it might? And so there's 3 trials here. I know it's hard to just sit and look at data, but there are 3 trials here that I'll go over quickly, and the last one has some really remarkable data in it. So this first smaller trial looking at FOLFIRINOX, again, this is locally advanced, so this is pretty aggressive vascular involvement. They looked initially on resectable and borderline resectable, so it's a little lesser degree, but still involving the major vasculature. So 43 patients got the FOLFIRINOX. It's a modified dose, and so they decreased the doses a little bit so that it made it a little bit more tolerable for the patients. They used radiation prior to surgery as well, so they definitely had some significant diarrhea and neutropenia, thrombocytopenia, but overall, almost 3/4 of the patients made it to surgery, and of those, overall, half of the patients were actually resected. And again, a lot of these patients were initially unresectable, and there were 25 patients who were thought to be unresectable up front, and 11 of those patients actually got their resection. So it suggests that we are seeing some retraction of the tumor away from that vasculature that was making it resectable. And interestingly, our R0 resection rate, these patients, these people are looking very aggressively for the margin positivity. 86% of their patients were margin negative. And we're very, as I say, we're very well aware of this problem with the margin negativity issue. So the pathologists are much more aggressive today than they used to be. This is the second trial, and it was published in Annals of Surgery just recently. It was a French trial with 11 centers. 77 patients got FOLFIRINOX. Again, this is locally advanced disease, and there were some significant toxicities as it was given. There were no deaths, but 6% of the patients had to stop the treatment because it was that hard on them. The disease control rate, 84%, meaning that it did not progress, and 84% and 28%, they actually had shrinkage of the tumors. 75% went on to get radiation prior to surgery, and the third of these patients ultimately ended up getting their surgery with curative intent. And the only outcome they gave us was their 1-year progression-free survival, which was actually pretty good considering these are locally advanced patients up front. 60% of patients with no progression at 1 year is an impressive statistic. And then finally, this is the most interesting of the papers that came out of the Mass General, and it looked at 188 patients who had locally advanced or borderline resectable disease that got FOLFIRINOX, and the patients were kind of broken into 3 groups. So these are patients who had resection up front with no neoadjuvant strategy, and then these are patients who had neoadjuvant. Of the FOLFIRINOX group, most of the patients had some form of either chemotherapy, pre-op and intra-op chemotherapy, proton beam. There's a handful of other schemes, but most of them had some form of radiation with their FOLFIRINOX. And this is the results that they saw. And so the first thing we see, if you look at these top 2 lines, OR time and blood loss, in the patients who did not get neoadjuvant treatment, they were better than in the patients who did get neoadjuvant treatment. So there's less blood loss, and the OR times are taking longer if they gave neoadjuvant. A lot of that probably is patient selection, because obviously if you've got a small tumor that's not touching anything bad, then those are going to be shorter, easier operations with less blood loss. Versus if you have tumors that are big and bad and invading the vessels, you expect them to be longer, slower operations with more blood loss. So that's kind of expected. But what was very much not expected was if you look at the post-operative complications with no neoadjuvant, 60%. That's really counting complications the way we count them today. Which is any little bump in the patient's post-operative course. That's about what you expect to see. But in this group of FOLFIRINOX, that rate got cut in half. Our biggest and most feared complication are these pancreatic leaks and fistulas, and they had 20% in the patients who did not have neoadjuvant treatment, which is about what you'd expect. No patient with FOLFIRINOX and radiation ahead of time had it. The length of stays in the hospital were shorter with the pre-treated group, and the readmission rate at 90 days, which is a good marker of how well you're doing with your surgery, was substantially different in the patients who had the preoperative treatment. And then finally, dead of disease. This is fairly short follow-up. It's only 11 months, but you can see that the survival, there were fewer patients who had died of their disease in the pre-op treated patients. And again, this was more aggressive disease in this group of patients. So that was pretty shocking data. So in summary for that data, FOLFIRINOX resulted in significantly lower operative morbidity. It shortened the length of stay and the readmission rate. Mortalities, they called essentially equivalent. On final pathology, the FOLFIRINOX group had significant decrease in lymph node positivity, so we reduced the node positivity rate by 50%. And then this is what really got our attention, is despite the postoperative FOLFIRINOX imaging, meaning they gave the FOLFIRINOX and then they looked at the CT scans, and the CT scans suggested that they were still unresectable. So the tumors didn't look like they retracted back. On imaging, they looked like they were still unresectable. But the decision had been made to explore all of those patients in this particular group of patients. And when they did explore them and they did the resections, 92% of these patients had margin negative resections. And so what happens when you get in there as a surgeon, this desmoplastic reaction in the gland makes the entire pancreatic gland hard. So you may have a lesion in the pancreatic head, but if you grab the body and tail, it feels like a rock. So you really can't tell by touching it where the tumor is. And so in the old days, if we had to get in and start shaving the tumor off the blood vessels, we knew there was going to be some microscopic cancer in there. Those were always margin positive. But when they do that today, after the FOLFIRINOX, they had a 92% margin negativity rate. And so it's made us completely rethink what's unresectable. So, and again, the median follow-up, as I said, was looked good for the FOLFIRINOX group. These are the survival curves. These are obviously you can tell by the survival curves, they're very small numbers, but it's intriguing data. So with all of that, we've changed our treatment algorithm, and the historical or resectable, unresectable has gone away, and so now we still have resectable up front and unresectable. Again, it's very small lesions that aren't touching anything. We'll typically take the surgery up front, although I think that's changing. I'm one of the people that's making a heavy argument that all of these patients should be getting neoadjuvant chemotherapy. And then if they've got metastatic disease, they're unresectable, but these locally advanced patients are being moved up into the borderline resectable category. And so these patients are going to get neoadjuvant treatment. So the patient walks in the door, this is kind of my summary slide. The patient walks in the door with potential pancreatic cancer. They get a pancreatic protocol CT scan, typically followed by an EUS and a biopsy. Every patient gets presented at our multidisciplinary tumor board. Anything but metastatic disease gets sent for a surgical evaluation, and that means even if it looks like it's locally advanced and you think you may not ever get to surgery, they should still have the surgical evaluation up front in this new paradigm. And part of that is this prehabilitation. I'll show you a slide on that in a moment. The majority of these patients are now getting neoadjuvant, and there's debate. There's actually a couple of very good studies out there going on right now looking at modified FOLFIRINOX versus Gemabrax. FOLFIRINOX does seem to give us a better local response rate, so if the patients are young and healthy, we tend to lean towards FOLFIRINOX. Gemabraxane is a little bit better tolerated, but still gives us a reasonable response rate. So if the patient's a little bit older or has comorbidities, they may get Gemabrax up front. We typically give them 4 to 6 cycles, so that's 2 or 3 months of chemotherapy up front, and then we reassess them. And if the response is good, if they're tolerating it well and the tumor is shrinking, then now in the old days we used to say, that's great, let's take the surgery. But now what we're actually saying is, well, if it's good, let's go ahead and give them some more. So they'll typically get another 2 to 3 months worth of chemotherapy at that point. Whereas if the disease is stable, meaning it hasn't changed, or if there's local progression, they're still resectable, at that point in these patients we might consider adding radiation therapy prior to surgery, but then taking them to the operating room. And we have to, and again, with this new paradigm, if the apparent radiographic extended vascular involvement does not change significantly, we're probably going to explore those patients regardless. And I can just tell you in my anecdotal experience, I would say probably 3/4 to 4/5 of the patients I'm taking to the operating room in that setting, I'm actually able to resect and our margin negativity rate seems to be about the same. It's about this 8%. So we are getting much more aggressive. I just want to take a second to talk about prehabilitation. It's a new concept. This shift from surgery up front to surgery after 3 to 4 or 6 months worth of treatment has given us an opportunity to look at whether or not we can make our patients better for surgery. Can we improve our outcome by doing things with the patient ahead of time? As I said, the morbidity and mortality following a pancreatic surgery is pretty substantial. So counseling the patients about the surgery ahead of time helps kind of answer a lot of questions for the patient's family, makes them understand what they're really getting themselves into. We send all of our patients to a high-risk perioperative hospital. So now we've always had a multidisciplinary team with a radiation oncologist, medical oncologist, radiologist, with a GI, but it's absolutely crazy that we don't have an internist who understands the specific care that's associated with a high-risk surgical patient. I'm 25 years out of my training now. There's 4 new classes of cardiac drugs that come out every year, and how they interact with each other and what post-op beta blockers my patients should be on. I just can't keep up on all of that, and pulmonary medications and diabetes management and such. So we have integrated an internist who does nothing but take care of patients who are either about to undergo or have just had major surgery. And we're actually publishing on this, and there's some evidence that things like the bounce backs to the hospital once we discharge to the patient, how often they come back to the ER within the first 30 days. Our rate of ER bounce backs has been cut in half by having this internist there working with us and taking care of the patient post-op, making sure their medicines are optimized, and making sure they're communicating well with their receiving physicians on the outside. We get the patients plugged into physical therapy, pre-op nutrition. There are a number of new studies showing that we can improve their nutrition preoperatively, and this includes probiotics, and if we get their albumin up, their outcomes are going to be much better. Psychosocial distress, for those, are we COC accredited here? So you're dealing with the psychosocial distress issues right now. For us, the problem is it's overwhelming our social services. We just don't have enough, because almost every patient who gets diagnosed with pancreatic cancer hits a 5 on that scale and needs to have it, whether it's financial issues or family issues or work issues. There's always huge problems for somebody with this new diagnosis. We can treat anemia ahead of time, vitamin D replacement. There's a whole laundry list of a very thorough protocol we have for what we call prehabilitation. So we use those couple of months ahead of surgery to get the patient into their best preoperative condition. So we've covered a bit the magnitude of the problem. It's soon to become, we think, the leading cause of death in the cancer death in the United States. We've talked about the initial evaluations, the role of neoadjuvant chemoradiation. I definitely believe that the neoadjuvant treatment is going to become the standard of care. I think even patients who walk in the door with resectable disease today probably will be shown to benefit from treatment up front. There's a couple of large national multi-institutional trials that are currently looking at that issue. And then this surgical prehabilitation, I really think that it's going to help us further improve the outcomes of patients who are undergoing pancreatic surgery. So I'll stop with that, and I'm happy to take questions. Yeah.
How long, or what's the time gap between the end of your neoadjuvant therapy and taking him to surgery?
It's a good question. It's typically 4 weeks is about the target that we're looking for. If for chemotherapy, 2 to 3 weeks it may be adequate if they're otherwise pretty healthy. Radiation, I didn't get into this issue at all this time, but we're using a lot more SBRT now. That's part of several of our research protocols as opposed to standard fractionation. And I think that's probably the direction that we're going to be going. That causes a really significant inflammatory reaction in some patients. There's kind of a spectrum of how much inflammation you get there and how leathery and hard the tissue becomes to operate on. It seems like our best window is somewhere between 4 and 12 weeks after the radiation, whether it's standard fractionation or SBRT. But that's one of the issues we're looking at right now.
Chemo, you can do it quick.
Chemo, if they're only getting chemo and if they recover pretty quickly, then 3 to 4 weeks I think is adequate. It's hard getting the biggest issue I have right now is patients walk in the door, they've got this new diagnosis of pancreatic cancer. they're like, well, what are you doing this afternoon? I want to go to the operating room now and get this thing out. And so there's a lot of educational process that goes on about it. And I show them the pictures, I show them images like this, I show them their CTs and the relationship with the tumor and the inflammatory stranding. And most of them get it at that point. So it's not hard, although I have to say, the patient that I showed up there with that inflammatory surrounding, tissue surrounding the SMA, I told him I wanted to do neoadjuvant. He was technically probably resectable, but he had that, so I thought that counted to make him borderline. I sent him back to the medical oncologist who said, no, he needs surgery up front, and talked the patient into that. So he's getting a surgery up front. So I'm hoping we can get a negative margin in him, but that's, you know, that wouldn't be my first choice if it was me. Questions? Okay. Thank you.
If we were sending a patient from here, if we were sending a patient from here, how much workup do you want before they get there?
The pre-op CT scan and potentially the endoscopic ultrasound. I think that both of those are beneficial. I'll say that you know, I put up our multidisciplinary tumor board. We have a great multidisciplinary tumor board. It's in the Providence system. You can get on it online and phone in, and people from all over the Providence system regularly do that. It's every Wednesday morning from 7 to 9. Juan Mejia is in Spokane. I know that you guys have been working with Juan. Juan is absolutely fantastic. He trained at UPMC and at the Mayo. Technically, he's an outstanding surgeon, and he's a very good resource for any of your liver pancreas patients. And he routinely uses our multidisciplinary tumor board. He works with our group as a kind of much bigger team. Yes.
So for the primary care docs and other care providers, what little risk factors do you take into account, other than those symptoms you mentioned?
Yeah, unfortunately, there's not a lot of very strong markers. So the ones you would expect. There's a relationship between smoking and alcohol consumption. There's a slightly higher incidence of pancreatic cancer, and then family history. And if you have one family member, if you have one primary family member with pancreatic cancer, then their family is actually 7 times the normal incidence of getting a pancreatic cancer, which sounds like a lot, but if you think about how rare pancreatic cancer is kind of across the whole, it's not enough to make screening worthwhile. The biggest problem we run into with screening these days is I say that the imaging is so hard to identify those tumors, and you get these really high quality screening exams, and you look at them and you'll see lots of little lumps and bumps, and then the onus is on us to prove that it's not a cancer, and that's really hard. And for a while, we were resecting every little cyst or every little lump we saw, and then we started realizing we were probably inflicting a lot more damage on our patients than we were preventing. And so the balance right now, there are some familial genes that have been identified for patients who get early onset pancreatitis without alcohol and without stones. And if the 30-year-old walks in the door with no clear etiology of their pancreatitis and it's recurrent, they should get a genetic screening, because there are a couple of gene combinations that will give them as much as a 50% likelihood of developing pancreatic cancer during their life. So that specific subgroup of patients you might do a prophylactic total pancreatectomy on. But it's a pretty rare incidence. Yes.
So I didn't see any mention of pancreatic protocol MRI. You don't routinely use it, or do you?
That's an institutional dependent. If you go to Sloan Kettering, they live and die by MRI. We have a much better MRI program than we used to. For liver now, we use MRI as kind of the standard. There are certain indications where that's really the only way to go. Pancreas, for the level of anatomic detail, I still feel is better with these really high quality CT scans, and that's really what we're looking for at that point, especially now that we know whether it's MRI or CT, they've looked at both the Mass General data. It didn't make any difference. It wasn't like one showed them it was resectable and one showed it wasn't. If the tumors abutted, it looked pretty much the same in both. So I think it's whatever your institution's good with.
Your SBRT, is that a national protocol, or is that something regionally that you're just trying?
It's still at a regional level, so we've been playing with it. There's Joe Herman, I don't know if you're familiar with that name, he's big, and I think he's actually at Mass General still, and he's been publishing a lot on it recently. It's gotten enough play these days, it's being used broadly enough that there's actually a very interesting multi-institutional trial. Matt Katz, pancreatic surgeon at MD Anderson, and that it looks like this is going to be approved, where it's going to be neoadjuvant chemotherapy with or without radiation pre-op for pancreatic cancer. But the radiation, they're actually allowing institutions that do SBRT to do the SBRT and then others to do standard fractionation. It's going to muddy the outcomes a little bit, but they feel like that's the only way they're going to be able to get this study done.
And are they doing SBRT on node positive by PET, or are they just doing the primary?
I think the majority of them would lean towards just doing the primary. I know that Joe published, he presented some of that data, and it gets kind of messy, and so I think he still considers it a potential for nodes, but I think most people don't.
Would you come back and talk to us about liver cancers?
I'd love to. I'll come up to Missoula anytime. And there's a lot, there's some real changes in our management there as well. Okay, thank you.